English speaking? Whose first language is, or whose best language is English? Okay. And the rest is French? No, neither. Okay.
I'm prepared in English.
Well, we'll do this in English anyhow, in part, yes. So, welcome to this session, and the first speaker will introduce himself as to why he's doing this topic.
Sure. Can you hear me well? Are the microphones working all good?
That didn't work?
Okay. Yes. Hello, everyone. My name is Thomas Agoritsas. I've prepared these slides with Silvie Touveneau here. We come from the University Hospitals of Geneva, and we're very happy to present to you our work on a patient partnership platform that we have built. I'm an internist by training. I'm not an infectious disease person, very interested in patient partnership, guidelines, recommendation. And Silvie Touveneau is really the nurse by training, but project manager, headmaster, leader of this project. And we are fortunate to work with her. I'm talking about patient partnership. This is very much in line with many concepts, but patient-centered care mostly. So the fact that all the care we organize is organized to meet patient needs. It is also, I think, in line with personalized medicine. So the idea that we individualize decisions to a given context or to a given need, but keep up with the quality of care. And of course, it is in line with shared decision making, with making decisions together with patients. Are you still hearing me well? Yes. That's one aspect of it, but I think it's much broader. I think we are witnessing a paradigm shift, or even a revolution, some people say, with patient partnership. And sometimes this takes very powerful forms. I'm copying here the cover of the famous British Medical Journal, and it says, if you can read, "Let the patient revolution begin." So you see a patient that is really saying we make a revolution. So it's very powerful. It's meant to convey a message. Patients are here, and we are supposed to partner together. We also have a movement of too much medicine sometimes, over-diagnosis, over-treatment, that was very much driven by patients. You see it here. But there is an explanation to that. I don't think it's a revolution or a political revolution. And if you haven't read yet this book, Why We Revolt, by Victor Montori, I suggest you do, because it's really that explanation on why patient partnership is really a revolution. And I very much agree with him. He talks about kind and careful care. Kind and careful care. And I come back to these concepts because we always talked of quality and safety, which are very fine words. Quality is effectiveness in care. Safety is we don't harm you. But it's also very cold compared to what we try to do daily. And there is an attempt in this book and in this movement to try and replace safety by careful. I'm careful not to harm you, and we are careful in the organization of care, and we are kind in the sense that we try to be effective in meeting your needs and your health needs. So there is a movement in the words we use, in the ethos, in the practice. And we can resist it. When I say we, any of us, healthcare providers cannot feel uncomfortable, but we can also embrace it. And WHO, for example, has embraced it. We see here one of the movements, Patients for Patient Safety. They really acknowledge that telling our story as patients to catalyze improvements and organizing learning is important. Partnering with professionals to ensure patient-centered care. Facilitating a patient's safety through educating medical students and healthcare workers to work with patients. So this is a movement that has started. In the University Hospital of Geneva, we have also embraced it. Also in the strategic plan, it was a strategic plan 2020, and you see here the list of objectives. There are other things like clinical excellence, quality, social or environmental responsibility. But the first one is patient partners, and this is this project. It has a very, very ambitious objective, which is promoting patient partnership at all levels of the institution, no less. For all our missions, for care, for teaching, and for research, it's a university hospital, and at each consultation, encounter, patient stay, acute care, or chronic care. So the ambitious is very broad, and you see me coming, it's because the goal is to change the culture, is that people change the way they think about partnership. And I'll try to show you how we hope we are doing this. Changing the culture is starting by talking to each other. So Silvie and the team have organized lots of meetings, focus groups, gatherings, where we talked about themes like communication, shared decision making, and the words that came in all those meetings were used to create content, to create teaching. It's about listening, meaningful conversation, trust. The word trust came very, very often, building a new kind of trust. Mutual respect in everybody's skills, knowledge, and where they come from, and shared decision making. We've also extended the concept of partners. Who is a partner? So partner starts by P. We have 4 Ps: the patients, the providers, healthcare providers, the patient relatives, caregivers, the helpers, and the public. Every patient is a citizen. So really the partners can be anyone described here, and nobody is excluded. And it's considering everybody's skills, knowledge, and experience, again, to improve quality and safety. And as I mentioned before, you can also have in mind this careful and kind approach to really focus the care around patients. When people start the partnership, they really have to understand that patients have a unique experience of their condition. We as patients know a unique experience of living with the disease, the care we provide. Some clinicians have been hospitalized and say it's completely different when I'm on the other side. I thought I knew what was happening, but it's completely different. It's a unique perspective, and this is where we talk from. We have thought a lot about the different levels of partnership. You know, what could we partner for? What kind of elements? And this is simplified, but you have the individual approach at the top and the community approach at the bottom. It really starts by partnering for my own care. I'm a patient, I have a given problem, I take the role of a patient now, and so I expect people to partner with me, share decisions with me, engage with me on my own level. But patients can also partner, and professionals, to improve the quality of care, not just their own care, but the quality of care in general, how a unit is organized, how a care pathway is delivered, how a reception desk is structured, and how we get phone calls. So everything that improves the quality of care, the pathway, the flow, and also research. So you see it could be quality improvement project, teaching to professionals, to students, to partners, to patients, and research in answering clinical questions. So we go a level up. There is also a level above, even more ambitious, which is partnering at the institutional level, at the leadership level. So having patients in committees, directorates, commissions, partnering with the institution, and maybe have a say at that level too. And this, at the beginning of our project, sounded ambitious / maybe a little crazy, but we noticed that it was already done in the hospital at different places. Different committees have already started on their own in partnering with patients. So this is happening. And theoretically, or not so, a 4th level, which is every patient being a citizen at the healthcare policy level, being able to partner with high-level decisions. I'll come back to this slide, but I think it gives you an overview of how broad this can be. So what have we done is very practical. We created a website. The address is here at the University Hospitals of Geneva, with lots of resources and where we come from. The website helps you navigate across existing partnership, because we really started by identifying and mobilizing existing teams. What is being done? And you can play with visuals to really go across the hospital in the consultation and see where we partner with patients. Lots is being done and was done, and this is a first step in changing the culture, is to know it. Then it's to network with the new partners, all the new Ps that come in, and I'll talk about recruitment. A website is not enough, so you have to really do the work, and this is where Silvie Touveneau and her team comes in. They really act as patient liaison. They liaise with the patient in making this happen. And even also developing training at different levels for that partnership, in having the critical, constructive communication skills to work as partners. And when we say this, it's not just for patients, it's for all the partners, so that professionals also have the skills to connect. I mentioned patient liaison that Silvie Touveneau is doing. Let me break it down in a few steps. When we are being approached by partners, patients or professionals, first we need to discover the project, the intention, or what has been started, the process. Assess the feasibility of that partnership. And I like to stress out, it's not so much if patient partnership makes sense, but rather how. There probably is always a way that patient partnership can work, but it's a question of how is it helpful in this project or with this intention. We have to identify appropriate partners. We need to know what we expect of those partners, professionals and patients alike. And then we have to find them, the recruitment, if they're not yet found, and prepare those meetings with them. Then the sensitive moment, you have to put people in touch together and have that dance, that conversation so that partnership happens. And then you have to continue and support, particularly the patients, until it's not needed, until the process has happened and the partnership has worked. So patient liaison is really this work being done since 2016 in the hospital. You also have to recruit people. So here I briefly mentioned to you, and I hope the slides are available, at least 4 ways of doing it. The first way is the networking, the professional networking. We ask colleagues by word of mouth, do you know patients that you feel could help us with that project, would be interested, have the skills and maybe are ready to work at that level. The pros of that approach, it's very rapid. It has limited follow-up because people know each other already. They will continue in that partnership. But the cons is that it may self-select the same type of patients. Patients, clinicians need to have, and maybe not a broader perspective. With the platform that we showed you, there is a recruitment through the platform. And so far, with the work done by Silvie Touveneau, more than 500 patients and family caregivers are now in our database, available to be contacted by email first and then get to know a project. And the pros, of course, is that it builds a network, a capacity to partner with more projects in other fields. The cons is, as you can imagine, it's work, money, time, skills in doing it to keep it sustainable on the long term. You can also just go through the list of patients, the very, very old traditional way. Who is hospitalized today? Who is coming to the consultation? And approach people. Phone conversation, written invitation, reminders. Low yield in recruitment, but maybe it opens up the variability of people you can approach and include them on the platform, so complementing the platform approach. And finally, social media. So previously it was a crazy thought, but now you can't enter a unit where you find a bed with no phone, no iPad, no tablet of some sort, and people are really connected through social media. So this is taking up, particularly in research, but it may self-select, again, some patients that are more prone to social media. We also, when it's very formal and really something is expected, more than a one-shot interaction, do a written mandate. We write down the expectations, the requirements, how you enter the partnership and how you can exit it, because nobody has to stay in a partnership, particularly when people are sick, mostly patients, but professionals too. What's expected in terms of tasks, of hours, so people can relate and talk about it. Recommendations on how to do that partnership in a given project. There is also clarification on compensation. Do you receive any financial compensation? I'm sure it will come up in question and answer. Reimbursement when necessary. All the contacts, so it's very formal. People know who are the partners and they commit around that partnership in a mandate. And so this has been done now in patient partnership project. So I'll give you end up with a few examples. At the first level, I said partnership for my own care. This is really, among other things, shared decision making. And just give a definition here of how we approach it in our institution, in the teaching we give. Shared decision making is a process by which a patient and a clinician work together, have a conversation. This is by Victor Montori. It's really that back and forth. It's not downloading an information, but really converse about it. And they partner with each other to find the best course of action. You have a nosocomial infection, you have a new condition. Are there options? And what matters to me and to us in those options from both ways? We share what matters. We share our knowledge as clinicians, and patients share their knowledge as patients. This is a true partnership. We also have very operational definition. This is from Glyn Elwin, which is useful to structure the care. The team talk, option talk, and decision talk, for example. Team talk is really, let's try and work as a team patient and caregivers, extended team as well, to make a decision together. So you have to lie down that there are options and then move to the option talk, contrast the options that you can face. And the decision talk is really important. We're not giving up. It's a partnership, so we have to work together to a decision. What matters to you? Where are you at the decision steps until we lead it? So we try also in teaching to implement this across the program. Examples, and there are many, many in our project, of the second level, how to improve quality of care and research. Silvie Touveneau has organized with her team many opportunities for that, cross-analysis sessions. You have a small picture here around themes such as communication, shared decision-making, care plans, end-of-life care. We could have nosocomial infection, any topic you find interesting. And you put partners together and patients together. You have witness storytellers of their own experience. People think and break down in brainstorming. And this is really a source of data. And we involve patients at all levels: project design, preparation and conduct of the sessions, analysis of the data and the recordings of the discussions to create teaching material for the partnership. So this is really very prolific. There are examples like this one where patients co-organize conferences and participate. It was a prevention day for cardiovascular disease, collection of needs during focus group, preparation teams where patients are involved in the organization and they help with the meetings. Quality improvement projects, there are many. I just outlined one, which is a famous hackathon. I don't know if you know the name, but it's challenges to find solutions for given problems. So patients are part of the teams, co-create solutions, but they're also part of the judges. They judge the solutions. There are patients that are involved as judges in the private foundation to allocate money, so prioritize projects that are patient-driven, patient partners. So this is happening as well. And another example, I could give you many, but we just picked a few, where they create toolkits. So partners with patients create toolkits for patients, sharing their experiential knowledge. This is one example from plastic and reconstructive surgery that was done together. I'm particularly involved, I talked about research. This is also happening through our institution. You have references, and I'm happy to talk more. I don't have time here, but we develop evidence synthesis and guidelines, international guidelines, where we involve patients. This is the BMJ Rapid Recommendation Project led by us. And we create panels of people, 20 people, professionals, but also 3 to 5 patients every time. So patients really work with us in making their recommendation for their own care. And this is happening as well. It's been done for now among 450 panel members. You have about 1/4 that is patient partners. And I'm happy to discuss this. We have gone through large databases of patient experience. This is really data, patients coming with information and stories. This one is from Oxford, healthtalk.org, and we categorize what patients talk about. And you see here examples briefly. First line is they talk about the care, the medication routine, tests and visits, procedure and devices that are offered to them, recovery, challenges around the recovery and adaptation. The last line is very important, daily life, what I can eat and drink, exercise, my social life, my work and education, whether I can travel or not. Doing this exercise is a very good teaching experience for providers because we just realize, rediscovering the obvious, that in any decision making, any care, this dominates. All of these aspects play a major role. So we do that too. I don't have time to give you many examples on the 3rd and 4th level. They are more ambitious, but it has started. Patients are now being involved and recruited for a few committees or commissions at the University Hospital of Geneva, and we look forward to make that happen more. Just one indicator of activity, since March 2016, there are 432 patient partners involved in 748 partnerships. Just the numbers, of course, every project is not perfect in terms of partnership, but just the numbers, when you talk to leaders in the hospital, they blink. They say, oh God, this is happening. The projects are happening because you can't have that high number if the machine is not in place and the liaison is not happening. So this is working. I've just put a few graphics. It's steady, even increasing now in the numbers of projects. You see most of the project on the left is about care, it's in blue, but teaching and research is going up. Many of the projects are more consulting. In the partnership, it's more about knowing what patients feel and want, but now it's moving to action, really building the solutions together, and direct involvement in the project rather than just being satellite, really coming closer. So the numbers are up, and this is really thanks to Silvie Touveneau and her team. I'll end up with some reflections about the gains. It's more qualitative, but for patients we see having a say increase their resilience. They really feel more committed. There is a building trust in the knowledge and skills that they have. For healthcare providers, there is an enhancement of our practice. It's all about having the experience that it works, so letting go of objections, but also then realizing that it's really helpful, that it saves time to have patients up front. For the institution, they just noticed that the platform was implemented. It was not done by magic, but it was done. It was done rapidly. All the departments now are getting on board. There is a visibility, obviously we're here and be able to talk about it. And we feel there is a prevention of incidents and conflicts that can happen through more partnership of that kind. And for all, it's about quality and safety of care. I would just rephrase again, kind and careful care in our institution. Risks is that some people still will resist the approach, of course. We are more working with the early adopters, but it's expanding. Those that are engaged, you can have a disengagement. It's work, it's fatigue associated with increased work. And the factors are, of course, the usuals, limited time, workload, etc. Fear of change, maybe, of fearing of getting judged. When you do partnership, you can just do the project on your own a Saturday night. You have to expose your project to other people and talk about it, so you may fear that. And limited funding if funding becomes an issue. The next steps are really achieving that patient-centered care. We are not entirely there, but we are going there. Training everybody, so we are working on training modules across the institution and the university that harmonize this experience. Maybe assessing that it does change something on the impact on quality, safety, and patient satisfaction. We haven't shown it yet formally. In this conference, yes, but in other aspects, maybe not. And really also increase the patient partnership in research. This is starting, but this is not yet at a broad level. So I invite everybody to step in the boat, and I thank you for your attention.
So thank you, Thomas. The schedule says that we should do the questions at the end.
Okay.
So I would have had questions myself already, but I will follow this. So our first patient, and perhaps we could have started with the patients and then ended with the future with that, but this is the way it was set up. So now we have the patient explaining their experience, and the first person is François Velen. As his name might let you think, his basic language is French. So I'm going to hear a sentence and tell you it in English. Hear a sentence and tell you it in English.
Posez des questions?
Vous commencez phrase par phrase.
Oui, mais il y avait des questions. Vous voulez poser des questions, Madame Touveneau?
Ah, que je lui pose une question. D'accord. Okay. So I'm about to ask him to describe his family life, his social situation, his professional situation before he had his health problem.
Ok, bien bonjour à toutes et à tous. Donc à cette période, j'étais marié, père d'une fille, j'exerçais la profession de clerc de notaire et j'ai aussi travaillé dans un service juridique de l'État de Genève.
So I was married, I had a daughter, I was working in a notary's office in Geneva on legal matters.
Je pratiquais la natation, la marche, la musique et je faisais partie de la musique municipale de la ville de Carouge. J'étais impliqué dans la politique, je faisais partie du conseil municipal de la ville de Carouge dont j'ai été 2 fois président.
So I practiced swimming, walking, music. I was part of an orchestra. I was involved in politics. I was part of the municipal management of the town of Carouge, which is near Geneva.
Après cet accident de voiture, j'ai eu une douleur assez forte dans le genou droit.
So after his accident, a car accident, he had terrible pain in his right knee. That was in 2004.
3 semaines plus tard, un orthopédiste m'a fait une arthroscopie pour réparer le ménix et le lendemain, je me suis réveillé avec 42 fièvres. Le genou avait doublé de volume.
So 3 weeks later, after this pain had occurred, an orthopedist did an arthroscopy to repair the meniscus, and the next day he woke up with 40 or 104 fever, and his knee had doubled in size.
Entre 2005 et 2008, j'ai eu des ponctions, des nettoyages, des opérations. Au total, 52 interventions sur le genou.
So in the following 3 years, there were 52 sorts of operations on his knee, all sorts of cleaning and extracting fluid.
En 2006, c'était la première pose de prothèse qui s'est infectée. J'ai été hospitalisé plusieurs fois dans diverses institutions. J'ai changé d'hôpital en fonction des avis des chirurgiens et des décisions que je devais prendre.
So the following year, 2006, they found that it was the first prosthesis that had been infected. He was hospitalized several times in different places. He changed hospitals when surgeons suggested that there were different things that should be done.
En 2007, j'ai eu une deuxième prothèse qui s'est également réinfectée.
So in 2007, he had another prosthesis that also got infected.
En 2009, j'ai eu une arthrodèse et il y a toujours eu des problèmes, ma jambe étant raide. En 2017, le matériel interne était à nouveau infecté.
So in 2009, he had an arthrodesis. There were more problems and his leg was completely stiff. And by 2017, they realized that what they had put in was infected.
Début 2018, le matériel a été retiré et depuis, je n'ai plus du tout d'infection. Aujourd'hui, j'ai des douleurs chroniques et je dois vivre avec celles-ci jusqu'à la fin de ma vie.
So in 2018, they finally took that out. He has no more infection, but he has pain, chronic pain, and problems that he'll always have. So the question I have for him is, how did you live through all these difficulties over 15 years?
Entre 2005 et 2009, j'ai passé 75% de ma vie dans les hôpitaux avec des traitements d'antibiotiques et j'ai été équipé d'un cathéter de longue durée pour 1 année.
So for 4 years, between 2005 and 2009, he spent 3/4 of his time in hospitals with antibiotics. He had a long duration catheter for almost a year.
En 2006, j'ai fait une tentative de suicide. J'ai pris de l'alcool et des médicaments. J'ai dû être réanimé.
After the first year, and I hate to say this, he made a suicide attempt with alcohol and drugs and had to be revived. But here he is.
L'entourage familial m'a beaucoup aidé à lutter. Ma famille, ma fille a vécu tout ça avec beaucoup de courage. Aujourd'hui, je fais de l'auto-hypnose pour parer aux douleurs.
So his family, of course, without which he could not have survived probably, his family, his daughter, and he does a lot of self-hypnosis.
J'ai eu des arrêts de travail ponctuels et répétés. En 2008, j'ai arrêté la politique par force des choses. En 2009, l'Office cantonal du personnel de l'État de Genève a décidé de me mettre à l'assurance invalidité.
So with regards to his work, as you can imagine, he had all these work stoppages. In 2008, he stopped getting involved in politics. In 2009, the official medical office of Geneva gave him invalidity insurance, so he's an invalid.
J'avoue que cela a été un double choc tant physique que moral.
So this was a double problem. First you had all the body physical problems and then the morale. And now, how do you live with this?
Pour améliorer cette qualité de vie, ma qualité de vie, j'ai un traitement au quotidien de morphine. Malgré cela, j'ai vite très mal, je dois bouger pour éradiquer les douleurs.
So I would not have guessed, that's me speaking, but he has treatment by morphine in order to have a sufficient quality of life, and even with that, he is in pain and has to keep moving.
Cette année, j'ai chuté à cause de cette jambe et j'ai dû être opéré de l'épaule.
This leg caused him to fall this year, and he had to have an operation on his shoulder. I can only imagine how you felt going in for a new operation.
Mais j'ai gagné, je fais de la marche, de la musique. Mais il y a des dégâts collatéraux. Les journées sont parfois longues, on a le temps de réfléchir.
I have one, I walk, I do music, but there is collateral damage. The days are really long sometimes, and I have a lot of thinking to do.
Apporter aujourd'hui mon témoignage, mon savoir, mes connaissances, ma souffrance me permet d'exister et d'être présent.
Bringing my testimony, my knowledge, my wisdom, my suffering enables me to exist and to be present.
Chaque jour, je lutte, mais je ne baisse jamais les bras. Et en définitive, ma jambe est devenue ma meilleure amie. Merci.
I fight, I don't let my arms down, I don't let myself down. My leg has become my best friend. So after that mild talk, the next person now is seated on my, oh wait, now you want the movie, yes. So the second person is represented by a film. It's Mélissa Rudolf, The Patient Partner Experience. And then we will end with François Lugeon.
Hi, Mélissa Rudolf. Thank you very much for being here today. Can you please present yourself and explain to us what brings you here?
Yeah, sure. So I'm 27 years old and I have a cystic fibrosis who was diagnosed at my around 8 months. So it was in 1992. So they made a sweating test and it appears that it was positive. It took quite long to diagnose because in 1992 it was not mandatory to do the sweating tests for newborn. Now it is, but voila. And I know I have cystic fibrosis in my 8 months, which was quite young. So now I'm dealing with that on my daily life, and so it was more something that my parents learned, so it was a bit different. I always knew I have a disease, so it's a bit different to me. And my mother was a nurse. I think it was also easier for us to deal with the news, maybe not with the news itself, but at least she understood better what the doctors were saying, and all the terminology and all the terms were easier for her to understand.
Okay, and when is the first time we talked to you about the risk of infections, which is...
So, as I was very young, I would say it was my parents who talked to me first about this. Because, okay, as a child, it's more your parents who talk to the doctor, and then your parents do that in your daily life. So they talk to me about how I have to do the physiotherapy exercise, how I have to empty my lungs from the mucus in order to keep it healthy and to avoid the infection. It's also taking the meds and all those stuff. It was really important for them to make it part as my daily routine. So the important thing was that, okay, you wake up in the morning, you eat, you do your breathing exercise, then you take your meds and all those stuff, and as cleaning your teeth, you just do your stuff for the disease.
Okay, that's good. So in your everyday life, you have those routines that help you deal with the disease?
Yes. I have to, okay, it's a kind of a strict routine, but you have to keep it in order to stay healthy and to reduce the risk of infection. So it's about, cleaning the aerosols and all the medical device, cleaning, sanitize, you wash, you make it dry well, all those stuff, just in order to keep the protocol really well applied. Take the meds, all those stuff. Also doing sport in order to empty much more the lungs and to develop more endurance also. And it's really part of the of the daily routine to keep the protocol.
And how is your family and your friends and entourage dealing with this and helping you through it?
Really nice, hopefully. they are really taking care of it as I don't know how to say, but it's really like they are just taking the lead of it. It's, for example, if I'm supposed to see someone and they are sick or ill or anything, and we are supposed to see each other, they will cancel and postpone our appointment themselves. I do not have to say, oh, you're sick, so maybe it's better if we... They do it, they take the lead and they do it on their own, because I think they really understood that it's important for me to keep my health on the good track. And I think they really understood that very well.
And how do you do when you meet new people or with people at work? How do you talk about it?
So when I meet new colleagues or friends or anything, I would say at the first occasion I have to talk about the disease, I will do it. I think it's important for people to know because of the risk of infection, so if they are sick they tell me and all those stuff. Also for just, spread the word about the disease. I think it's important for people to know what cystic fibrosis is, also because it's not a disease that can be seen, so it's also always a bit strange for people to say, oh wow, you do not look sick, but it's a bit different. And I think it's part of me, so it's also important that if people want to know me, they have to know that. And for my colleague, of course, they are spending so much time with me in the office and I'm coughing a lot, so they always have questions, so it's even easier to just say it because they will ask questions quite soon.
Okay. And when you do come at the hospital for an appointment, how do you see the staff interacting with you?
So I didn't realize that before doing the interview and before thinking about all those risks of infection, but they are doing a lot. So I personally do all the things with the sanitizer at the entrance and the exit, but then I realized, okay, each time I enter in a medical room, they put all the new thing everywhere. They are cleaning their hand, sanitizing. They are always putting masks if they are coughing a little bit, even just a little. And in fact, it's a lot because to me it seems totally automatized, and I never realized they do that. But when you think of it, it's quite a huge organization to put in place. And for waiting room, for example, and personally, I would have to say that I'm quite often alone in waiting room, so I don't know if it's something specific that has been put in place for cystic fibrosis people, but I realize I'm quite often alone in waiting room, and when there is someone, I'm always trying to, of course, but okay, it's also a social behavior, but you do not sit to someone you do not near to someone you do not know. But if there is a lot of people and there is someone coughing, for example, I will try to avoid to be near those people and all those stuff.
Okay, so you seem to really have a good handle on your everyday life with this.
Yes, I'm trying to at least. So,
thank you very much. Thank you very much for sharing.
Thank you. So, seated on my left, we have Mr. Velen. So I'm going to ask him the same question. Sorry, not Mr. Velen. Yes, Mr. Lugeon, excuse me. I'm going to ask him to talk about how this happened. How did your situation come to be?
Alors bonjour. Alors je travaillais dans les sports de glisse et en 2014 j'ai fait un infarctus du myocarde durant la pratique du wakeboard.
So I worked in sliding sports, and in 2014 I had a heart attack while practicing on something called wakeboard.
J'ai été pris en charge très rapidement par le cardiomobile et j'ai été transféré au HUG où j'ai fait un choc cardiogène avec nécrose partielle du cœur.
So they came and got me right away with the mobile cardio unit. I was transferred to the hospital where I had a cardiogenic shock with partial necrosis of the heart.
Je me suis réveillé 3 semaines après aux soins intensifs et durant cette période, j'ai eu une circulation extracorporelle suivie d'une assistance ventriculaire que j'ai gardée durant 1 année jusqu'à la transplantation en 2015.
So I woke up 3 weeks later in intensive care. I was on a heart and lung machine, then with ventricle assistance that I had for a whole year until 2015 with the transplant. What did you know about infections at that time?
Alors j'ai eu la chance qu'à l'âge de 20 ans, j'ai travaillé dans une société qui vendait des stérilisateurs et des produits de désinfection pour les cabinets dentaires.
So this is an amazing coincidence. When he was 20, he had worked in a company that sold sterilizers and disinfectant products for dental offices.
Et là, j'y ai compris les problématiques de transmission croisée et les problèmes d'hygiène.
So he knew all about cross-transmission and hygiene problems. And what information did they give you while you were being hospitalized?
Alors avec l'assistance ventriculaire, il fallait que je fasse attention aux orifices de tuyaux qui rentraient dans mon corps, car l'infection, elle pouvait suivre le tuyau et puis infecter le cœur. Et je devais également faire attention de ne pas mouiller les pansements pendant les toilettes.
So I was told that with the ventricular assistance, I had to be really careful about the openings of the tubes, that the infection could go down the tube and reach the heart, and I had to be careful not to get my bandages wet.
Alors après la transplantation, j'ai commencé un traitement immunosuppresseur et on m'a expliqué que mes anticorps seraient très bas et que je devrais faire attention avec les risques infectieux.
So after the transplant, I had to start an immunosuppressor treatment. They explained to me that the antibodies were very low and I had to be really careful about the risk of infection.
Alors ils préconisaient une désinfection régulière des mains, car la majorité des germes se transmettent par les mains.
They told me to be really careful about constantly disinfecting my hands because the germs would be transmitted by the hands.
Alors je dois faire attention avec tous les contacts de peau, les serrages de main, les bises, les poignées de porte, etc. Et j'ai eu conseil pour l'alimentation, surtout dans les endroits publics, et éviter les buffets et la nourriture non cuite.
So a lot of rules. I have to be careful with any skin contact, with handshakes, with hugs, with door handles. I had a lot of advice about the food I can eat in public places and to avoid anything that's not cooked in the buffets. So what impact has this had on your friends and family?
Alors je les ai sensibilisés à ce risque infectieux. Maintenant on ne se serre plus trop les mains, on fait plutôt des checks et puis tout ça pour me protéger. Donc les checks, c'est on se tape le poing et puis on se dit bonjour comme ça.
Okay, so now that they know all about this, we don't shake hands, we go like this. That's like Michelle Obama.
Ouais. Alors c'est pas très sympa de serrer des mains puis de se désinfecter après. Ça peut être gênant pour les gens, gênant pour moi aussi. Et la personne, elle peut quand même mal l'interpréter. Alors j'ai appris à faire la désinfection un peu plus discrètement. Je me retourne et puis je le fais discret.
So there's an impact on the other person when you don't want to shake their hand and when you are near them and use a disinfectant right after you're with them. So he has to hide it a little bit and disinfect his hands when he turns around. What else do you do every day to protect yourself?
Alors, j'ai toujours ma bouteille de désinfectant dans la main. Pour ceux qui travaillent au HUG, ils la connaissent. Quand je vais faire les courses, quand je vais au restaurant, je me promène toujours avec ma bouteille, elle est toujours dans ma main. Dans l'avion, je porte un masque de protection, je fais attention à l'emballage de la nourriture.
So, not like other people, he has a special bottle with him always. It's this product. It's not a bottle of alcohol. And when I go to buy things, when I'm in the restaurant, everywhere I go, I've got my little bottle with me. In the plane, I wear a mask and have to be really careful with the food wrappings.
J'évite de prendre des transports en commun. Je vais faire les courses durant les tranches horaires où il y a le moins de monde. L'hiver, pendant la grippe, je mets quand même un masque dans les magasins. Il y a le regard des autres, mais malgré que je sois vacciné, je dois quand même faire attention à moi et pas me contaminer.
So I don't take public transport, or I avoid taking it. I do my errands at times when there would be the least people around. And the winter, during the flu season, I wear a mask. People look. Even if I'm vaccinated, I still want to be careful and take no chances. And when you're in a hospital or a clinic, how does the prevention happen around you? What do you do?
Alors, une fois, en me rentrant à l'hôpital, j'ai une mycose du doigt qui m'a été transmise par un saturomètre. Et depuis, j'aime bien voir la désinfection, qu'elle se fasse devant moi, que je puisse voir les instruments désinfectés. Et en fait, c'est ma santé qui est en jeu. Et puis ça aurait pu être un staphylocoque doré. Puis là, ça se serait très mal passé pour moi.
So I had an infection, a mycosis on a finger that was transmitted by the little saturation measurer. And since then, I want to see right in front of me the disinfection happening. It's my health. It could have been a golden staphylococcus, and then it would have been awful for me.
En fait, c'est ma vie qui est en danger, puis je suis obligé de m'imposer. Je dois faire abstraction de ce que les gens pensent de moi.
My life is in danger, so I have to impose my way, and I can't care what other people think.
Et en ce moment, je me fais poser des implants dentaires. Et puis j'en ai informé mon chirurgien dentiste que j'étais immunodéficient. Et là, il m'a répondu que depuis qu'il y a eu la crise du HIV, ils ont des protocoles pour la désinfection. Et j'ai quand même dû lui répondre que l'important, c'était également de me protéger moi, pas que lui, de tous les risques infectieux.
Yes, that's a cute one. So he's having dental implants, teeth being put in, and he told the dentist that he was an immunosuppressed patient. And the dentist said, "Don't worry, we protect ourselves," referring to himself. There are protocols since HIV. And he responded, "But I'm talking about protecting me from the infectious risk."
Et puis maintenant, je me rends compte qu'à travers toutes mes expériences, c'est important que je reste attentif à ce qui se passe autour de moi et dans mon environnement et ne pas hésiter à transmettre mes ressentis et mes constats.
So I realize now that everything I do is important and I must remain really attentive to everything around me and not hesitate 1 second to say what I see, what I feel.
Voilà, merci.
Maybe you can't touch this, I don't know, but I brought with me something for each of you. Does anybody know what this is besides Frank? I know Frank knows what it is and Vanessa knows. This is called pink socks. So there's a guy in the US who created these pink socks. He has thousands of them. You buy them from him if you want to give them to people who are doing good in the world, pour des gens qui font du bien dans le monde. Et alors donc, il y en a un pour vous, et je le place là. Après, on peut prendre une photo. We'll take a photo. So, we have a few minutes for questions. May I ask a question? I'm going to take us out of this emotional thing.
Okay, I'll be rational.
Right, let's go back to the rational. So what kind of money are we talking about when you say you might pay a patient to participate in something besides their expenses? I've often thought about this issue that if they're a true partner in a research, shouldn't they be paid something decent?
It's a very good question, and we're facing it again and again. I'll try and answer, but Silvie, correct me if you have more to say. There is tension between saying, it should be volunteer work. You hear that. You hear people say it should be volunteer work because if you start involving money, it could somehow have some negative effect. I'm speaking of beliefs, not what I think, but negative effect on, not the right people coming to help and that they may come for the money, that it's not a job and things like that. At the same time, in the discussions we have, you can easily throw that back. I see that as a tennis play and say, well, all the other professionals around the table in a given project, in a research, are paid. And sometimes they're also paid for that project. And you may argue that this can also lead to a selection of people and the way they work and why they do this. I think it's, at least in our institution, an open but unresolved issue. There is a decision at this stage that there is some funding, which is not a salary, but a compensation of some kind, which is about 50 francs an hour, when there is a work involved, substantial work done in a mandate, with some rules of how much it can be, how much time. And the mandate also helps clarify that role. And you may have people expecting more. I'm speaking of patient partners, for example. Some people expecting less, This is for now, I guess, correct me, but a starting point. And I think it's an open discussion. In research, it's also an open discussion with the conflict of interest, increased attention of conflict of interest. But this is very interesting times because as we put more attention on conflict of interest for researchers, and partners are researchers and patients are researchers too, we argue that the same rules should apply. So you look for a systematic and similar approach. If nobody's paid, then it's volunteer work. If people are paid and there is compensation, then the same rules should apply. But there is probably a difference between the research world, I would think, and the clinical work. So unresolved issue, a choice by our institution to have something and rules, and adapt them. I don't know if you want to add something, I can translate. So this compensation is also lived as a recognition of the contribution and the work it involves. Many of the patients have chronic conditions, low income, no income, so this is also helpful to be able to have this compensation, and this motivated the choice.
So somebody must have questions for the patients. I will translate if necessary, or you ask it in French, whichever. Who has a question for the patients? Do you have a question for them? No? No? I will ask. Je vais vous poser une question, monsieur. Ah, yeah, oh, you have one. Okay, good.
I was just wondering, before these events happened to you...
to which person are you asking? Any of them?
All of them.
Okay.
Were you aware of hospital-acquired infections? You know, did you have information, and did you wish you would have had more information? Obviously, you knew because you were working in the dental office. And I guess what I'm interested in our research is how do we empower consumers before they become patients? Because once you become a patient, you become so vulnerable. So if you have all this information before, when you become that patient, you know what to ask, how to ask it, and what to do.
Oui. Est-ce que vous étiez, monsieur, est-ce que vous aviez une quelconque information avant de tout ceci concernant ce qu'on appelle l'infection acquise à l'hôpital?
Alors, j'avais aucune information en définitive. J'étais dans le noir complet. Donc, le lendemain que je me suis réveillé de cette intervention, la toute première, où je ne comprenais pas ce qui m'arrivait. Et là, le chirurgien m'a dit que j'avais une infection. Ils allaient faire des prélèvements, ce qu'ils ont fait. Et là, on m'a informé que j'avais des staphylocoques. Je ne savais pas du tout ce que c'était. Et au fur et à mesure des interventions, on m'a un petit peu informé. Mais c'est vrai que il a fallu lutter avec le corps médical pour savoir ce que j'avais, où j'allais, comment ça allait se passer, jusqu'au jour où on m'a dit en définitive qu'il voulait m'amputer. Et là, franchement, je me suis réveillé en disant « mais c'est pas possible, expliquez-moi franchement ce qui se passe dans cette jambe, est-ce que ma vie est en danger ?» Mais auparavant, aucune information, rien du tout.
So he knew absolutely nothing, and not only did he know nothing about the possibility that there could be an infection, even when he woke up and they told him that he had one, they were very sparing in the way they gave him the information, drop by drop, so he never knew what was going to happen next.
And it was difficult with, if I may add the translation, with the medical teams to learn the story, what happened, which I find interesting. It's all that idea of partnership daily on everything, so that it doesn't, it's not a battle to get the information and to be involved.
In the beginning of your talk, the first example you gave of partnership is a conversation.
Yes.
Well, every consultation should be a conversation. And then we see at the end that we're happy that there are a few hundred of these, whereas during that period there have been thousands of consultations.
Yeah, so the project I mentioned is not the conversation, but I get your point. When we do this research, we observe how people share decisions, how they talk. And I'll just tell you one anecdote, because I think they speak more than our numbers. There was a fantastic doctor, very skilled, motivated, knowledgeable, and it was something about thrombosis and an infection. And I heard the doctor talk. I was sitting in the next room waiting for my patient. And I heard him talk and explain well and be kind and give those explanations. I think it lasted 15 minutes. And I didn't hear the patient back. I heard some breaks and pauses, but I didn't hear the patient. And I thought, well, I can't hear him because of the walls, and I somehow hear the doctor but not the patient. And at the end, the doctor says, well, that's it. Do you have any questions? And I think we should see each other in about a year or so. And then I heard the patient says, why? So two things. They talked for 15, 20 minutes in a very nice way. I mean, he talked in a very nice way for 20 minutes. The patient heard, but didn't speak back because I didn't hear a word. And I think this conversation issue, if I stay at the first level, it may not be partnership yet, but it's a condition that we are not used to sometimes have. The doctors you saw, les médecins que vous avez vus, peut-être n'étaient pas habitués à vous donner les informations en continu. Et il y a eu comme un moment, the doctors that you saw, I asked, maybe didn't have the habit of sharing continuously the information with you.
Oui, alors je crois en définitive que le médecin qui était un médecin du privé, donc, n'avait pas le tact pour expliquer peut-être aux patients, parce que lui-même a été surpris, et je subodore qu'il a dû voir les ennuis qui commençaient tant pour moi que pour lui. Donc ensuite, j'ai posé des questions à ce médecin, mais toujours sur la défensive. C'est vrai qu'il répondait un peu évasivement parce que voilà, il voulait peut-être pas psychologiquement m'embêter. Et en 2004, c'était peut-être pas comme maintenant. Et en fait, où j'ai vraiment vu les ennuis, les gros ennuis et le mur qui s'était dressé devant moi, c'est au SACUG, à l'hôpital cantonal, là où c'est multidisciplinaire. Et là, il y a eu infectiologue, chirurgien. Et là, j'ai vraiment compris le sens profond de ce que c'était qu'une infection. Mais dans le privé, je ne sais pas au jour d'aujourd'hui, mais en tout cas en 2004, c'était pas la tasse de thé des médecins d'informer vraiment. Le chirurgien, c'est on met le coup de bistouri et puis voilà. Et puis après les ennuis, on les vit comme on peut.
Should I translate?
You can go ahead if you want.
So your answer was that in the private setting, the first component was maybe the doctor didn't have time, the surgeon, to share all the information, and later you thought maybe he worried about the consequences of sharing information about that infection, and it became defensive. And then it's when you arrive at the public care at the University Hospital of Geneva, you saw the specialists, infectious disease specialists and others, that you understood what had happened and the severity of it. So we see this partnership is really a culture shift, I think, in my view, that everywhere people get the habit. And maybe if I can add the fearless consequences, that it's always better to talk and have the conversation and be open and enter partnership than refraining from and being afraid.
Well, hopefully there is also a shift going on in the way students are self-recruiting into medicine and the way they're being recruited. I know that I've read things in the US about medical schools now looking more for the humanistic background of the person and not just memorizing. I think that our advances in artificial intelligence, where we're no longer going to be needing people who can memorize pages and pages of things, will help this. Hopefully our society is now more level than it was, and that people can speak out. But it's true that unfortunately a lot of the practicing physicians have no experience and in this kind of conversational mode that is necessary for people to learn. People do not learn if they are talked down to or told what to do without understanding why. Did you understand what I said? Oui, je disais que j'espère que la société est en train de changer, que le recrutement des professionnels est en train de changer, qu'on peut davantage aujourd'hui, comme ce que vous disiez, échanger à l'horizontale, parce que sans ça, il n'y a pas d'apprentissage. On n'apprend rien si on vous oblige comme ça. So we can, I guess we're reaching the end to really thank these people, and of course Vanessa, who poured her heart out last night at the meeting. These three very brave people to come forward and tell us what's going on in their body and in their mind. It's very impressive. So thank you very much for this experience. And thank you. Est-ce que je le garde ou vous le voulez? Parce que je ne sais pas pour les gens.
Ah non, moi je mettrai la machine à laver.
D'accord, ok. Ok.
Mais comme ça, c'est parce que ça, c'est le symbole de...